When you hear the tone, you will be the 45th person to join the meeting.
Very grateful. Thank you.
Thank you, Carol. Good afternoon. Thanks for everybody taking out their time to join us today to walk through this presentation and to partake in the information put together. It was set up so that it can help everybody down this wire that we have time frame to make sure that you are ready to move into October as prepared as you possibly can be for the other side. Today's agenda, we're going to start with discussing just ICD-10 coding and documentation training, financial impact, configuration of patient records, configuration of medical billing, testing internal and external systems, and then a little discussion on October 1st and beyond, monitoring information coming back in, and to kind of have an overall plan as to what to expect here in the next few months. So when we talk about ICD-10 education and training, more or less what really is very important on any sites is that they actually do some training, because there's so many changes with ICD-10 from what we've been used to for the last many years, that without that training, you're going to really walk into it with a lot of confusion and possibly difficulty being able to make that transition, as well as understanding what information is coming back to you or what is needed to be able to make the change that's going to be required in the future. When you choose the training, there's a lot of different options out there. There's some online. There's the AAPC offers training. Different organizations may as well that you join to. But things to take in consideration is that everybody the entire staff needs to be trained overall awareness, understanding what it is, what's coming across, and how that's going to affect them on their day-to-day work, including in what's going to happen inside of their application that they get in there and they work every day as to what those changes are going to be, so that they understand and help with the process of being able to implement and move forward. The documentation, again, as you can see in this slide, is that it can be broken down specific to what that staff member does or for the job. Obviously, if I'm not somebody that's really associated with coding and billing, I don't need to go in and do all this advanced training, because it's going to be more way over from what I really need on my job. If you haven't started any kind of training at this point, it's not too late. And I can't even stress the importance of getting it done on your side as the providers, on the whole understanding of what the code sets are, what's going to require of you specific to your site, and moving forward. Because even if you start now, understand that once we move into October and moving beyond, that training really is not and should not stop at that level, because we really are going to have to continue moving into this direction and start understanding what this change is going to mean to all of us, and to help yourselves out as you move into that future and the changes of information going on. The other thing is that when you look for training, look at training that's going to be specific to what you do, not something so global that it means nothing to you when you go out to train. It's just going to help in there to help you understand the code set and the documentation that you need to move forward in the practice. The next thing to start looking at with this is financial impact. And out there's a lot of information that's been put out for quite a while about the need of having money up front and that kind of thing if systems don't work or you're not getting paid. You know, we don't really, I mean, it may or may not happen, but on your level, I think moving into it, it's important to understand what kind of financial impact it's going to have. And the first and foremost is probably going to be the productivity of the staff, because you've got a couple things involved there. You've got overall learning curve for everybody involved. What we once knew was an ICD-9, now it's an ICD-10, and a lot of times when we go to look at those codes, the description doesn't even seem the same. We question as to what it is we're looking for, because what we called it in 9 may have a whole different meaning in 10, or there may be different guidelines involved and all that involved with that. So it is going to take some time on learning curves, as well as documentation time will start increasing on the provider end of it, because with ICD-10 comes the clinical documentation improvement rules that are going to be associated with that. So there's overall going to be a lot of lapse in there, and understanding moving into it that there will be some slowdown time that goes. You're still going to have training education costs. Again, you may have already been doing it all along now and still moving into it, so that is still something to think about and to continue through as we move in that direction. Also prepare for possible decrease in payments. I don't know that that is something that may or may not happen because we haven't seen any payments coming back for ICD-10 at this point, but it's also a good one of those things is that if you have it in your head that it may happen, then you're kind of prepared for it, but just think about that it could be a possibility. IT and support costs could also go up. Certain things could happen, issues with claims going out the door and so forth, so that's also something that to look at that may be in the mix of things. And then also changes in healthcare contracts. There may or may not be at this point, but what you want to do is prepare to start looking at that information as it comes in to make sure that you are getting paid according to what you've got as a contract, or if there's been changes that you're aware of that, to understand that what kind of impact that's going to have on you overall financially. One of the areas to think about is in the financial impact is what do you need to know now? What are you doing now? And moving into that, most of us close our month at the end of the month. We kind of have an idea about what our accounts receivables are, denial rates, amount of reimbursements that are being denied, certain things like that. If you're not really aware of what's going on right now, it'd be a good time to sit down with your billing department or your administrator and find out what is going on in that situation. If you've got a huge accounts receivable, areas that you're having concerns, because just because once we go to 10, those concerns are still going to be there. And it's important now to have a good idea about that so that you understand moving into 10, if things are going to start piling up, what kind of areas that maybe need to be worked on prior to even October 1st, which is getting very, very close. The other thing is to understand is right now, if you've got certain billing going out and you've got a lot of denials, what's triggering those denials? Is it diagnosis codes? Is it medical necessity that is getting denied back on that, and so forth? So it's just an idea to go back and look at that and kind of have that in your implementation so that you overall have a good idea of what's happening currently, and then understanding how this may affect you once we go to 10, if it's going to pile onto it or if everything's going to just keep on moving in a good direction. And then again, last is just looking at the current workflow for denials, tracking, and follow-up. Right now, if you've got a great billing staff and they're really working those denials and getting EOBs back out and doing the denials, that's a beautiful thing. If that person's going to continue doing it and you feel good about that, that's great. But if you're in a situation where maybe you're going to have some billing issues going on, definitely look at that and follow through so that you know that you've got a staff member in that position that's going to be able to handle any kind of denials or changes that come along with this switch over in ICD-10 and be able to move into action and allow those things to get fixed before they become a real problem later on. The municipal reports and medical billing, I pulled these. This is pertinent to practice partner medical billing, but if you're with Metasoft, LifeTech, or other systems, you have appropriate or more or less kind of some of the same reports that you could go ahead and run.
I'm watching an ICD-10 webinar right now. Oh, are you? With practice partner.
With medical billing and practice partner, one of the first reports to run in this implementation is the analysis of diagnosis report, and that is a report that's going to give you a summary of diagnosis codes being used. In any of the system that you're using, that is one of the most important things that you really need to run starting off. And
they can wait an hour or two.
The purpose of running this report is you're going to see in the next slide. It comes into a lot of multi-purpose reasons, but you highly advise, if you haven't run it, to go ahead and run that out of your system so that more or less it's going to give you a picture as to the diagnosis codes that you've been using common, and then utilize them to move forward and help with your implementation to make sure that you're getting it right when you move through. The analysis of service report in Practice Partner is going to give you a report of your procedure codes as well as reimbursement on those procedures. So again, with your financial impact and the financial plan and monitoring of things going on, this is a great report to go in and look at what you're getting paid currently, on the procedures that you're doing, and so that you know that those allowed amounts are coming in, and that'll give you a good way to go back in later on is in November when you start getting payments back in to make sure that those payments are still in line as what they should have been prior to. The accounts receivable, as I spoke of earlier, run that 30, 60, 90 to 120, however days you have that out there. Again, that's going to give you an idea of what you've got right now currently, and then if there's charges way out there, keep in mind once October rolls around, your September payments will start being paid, and hopefully by the middle of October you should start seeing payments coming back in from the ICD-10 code sets, and that's going to give you a good idea of knowing where that income's coming back in. Obviously, if you've got a lot of AR back to 60, 90, and 120 days, that's old accounts receivable, and understanding that that's money that's sitting there that needs to get worked and paid on, and if it's doable and done, then that is also going to be money that you can still have coming into you and get it cleared up there. So it's very important to run that accounts receivable and have a good idea as to where your money is right now, moving into it, and then understanding how that's going to go ahead and move forward once we change to 10. The other report in there is a practice analysis report. Now, this is pertinent to, again, medical billing out of partner, but you have a lot of different options. That is just a way to go back in there and look at your trending month to month. I mean, if you're used to having X amount of money coming in every month, that's going to be ahead and reported on that, and that's going to give you an idea by the time you get towards the end of November how much money you should still have in there. It's going to just give you a real good ability to kind of know that payments are coming in and you're feeling pretty good about that and not going to get to the next month and not have enough money to follow through. So it's just going to give you a good way to monitor and make sure things are going through the way they should be. And if not, to make sure that you're checking everything that you possibly can to get things to be moving through there smoothly again. All right, so now talking about just kind of preempt on certain things of being able to go back and check things up. The next thing is to talk about configuration in your system, because that's not just one of the important things about ICD-10, but it's how you're going to get your claims out and information that's going through. So it's very important that as we move into this, that you have done these steps and checklists to be able to make sure your system's up and running and have an understanding as to how it's going to work and what needs to get done or not done, or things that are going to just go ahead and take its place, but to know that when you're moving into that date, what to expect. In Practice Partner, under PR Util settings, in the Access tab, there is a default date in there, and it's currently October 1st of 2015. And what that is just saying to the system to turn on ICD-10 on that day. More or less, is that October 1st when you walk in, Practice Partner, turn it on, it's going to go ahead and recognize all of the codes in that system. They should be ICD-10 or used. Now, as most of us have been on version 11 for quite a while, and we understand that we need to have the triad of codes, the ICD-9 and the ICD-10 and the SNOMED. So if you've been working along that way all along and most of your codes are all mapped, then you're not going to have too much of a problem. But if you haven't and you're still haven't updated certain areas of the system with the mapping, then you're going to have problems as it goes through, because once that's turned on, then all of a sudden you're going to have warnings and so forth. So just keep in mind that the PR Util is automatically going to turn that on. There's nothing you have to do on that date. It's already set up, ready to go. So with this, and the same up as I just said, is that starting now, it's important that all the diagnosis codes used in the system are the triad code sets, the ICD-10, the ICD-9, and the SNOMED. So there's a couple ways to be able to achieve that. One is to be by adding diagnosis codes to the HLI web service. So if that's being used to add diagnosis codes to your notes ongoing, then that information is already pulling into it what it needs to do. The other thing is updated quick text for inserting codes. If the quick text has been updated in your templates, then that's also pushing over the triad codes down into your system and making sure those mapped. When you go into special features, so with the one setup, and that's really the one setup that you need to make sure that's checked in Practice Partner, is under Special Features Records 2. There's an ICD-10 warning on Save toggle. And you'll want to make sure that's checked, because if it's unchecked, then once that October 1st date rolls around, you're not going to have anything in the system that's going to pop up and say, hey, you're not using the correct code. Because basically at that point is if somebody's still trying to use an ICD-9 code, possibly push it down from a quick text, or if they haven't updated their problem list and they're trying to insert it into the order module or pull it over into the ledger, it won't pop up and give this warning. So you're going to want to make sure that that toggle is on and turned on into your special features moving forward, so that it does start flagging in the system and start sending warnings out, so that as people are working it, they can go ahead and get those codes updated. So earlier when I talked about running reports out of the system and stressed the importance of running a report of the top 50 to 100 diagnoses. That's just a given number in there. But the purpose of that is really, there's multiple reasons why to run that, because that is going to be your guide. It's going to tell you what diagnosis codes used most often. It's going to help you be able to go back in and go through the diagnosis table that we're going to talk about here shortly, and to be able to map what codes you possibly can in order for that to update the problem list in patient records as a whole. The second thing on that is that this guide can be used for you to go through and look at what is going to be required in ICD-10 for the types of codes you use. So if you use a lot of injury codes, you use a lot of codes with laterality, then it's going to be important that your site understands if they're going to be billing initial visits or subsequent visits, and the laterality.
That's right.
So that also is going to be a guide on that, and to be able to pull it. And again, if you can pull it in and put it into an Excel spreadsheet and map it that direction for everybody to help, that's very beneficial. And then the last is, again, if you have that and you want to be able to go ahead and implement it, if you're still using a paper electronic encounter form, you can go ahead and add that to your paper electronic encounter form, or transfer it and make sure your electronic encounter forms are updated with the correct information that's needed. So overall, that report's going to come into a lot of different tools to be able to use to move into it. And as I said earlier, implementing this needs to be specific to your site and the specialty you use. You don't have to know 63,000 codes. You just need to know what the codes that it is that you're using and how that's going to work towards you and what needs to get changed. So diagnosis code mapping, there's a lot of words use mapping. I know I've caught myself using the word mapping over and over again when sometimes that's not really even what I'm really referring to. The one thing to understand is with the mapping, the ICD-9 to ICD-10 crosswalk, that's really kind of what the mapping is all about. But you're going to always find, and you've probably already experienced that somewhat using the HLI lookup system, is that sometimes what you're expecting to see is not always what it comes back in the mapping, is what you're expecting to see. And so this conversion, that needs to be an understanding, and as you move forward to it, it's important that you start understanding the changes of how that goes, and then you may have to even refer back to your coding guidelines and information to get further information to better understand what it is that you're seeing when certain information comes up. I can tell you we've been on ICD-9 for as long as I've been in this business, and we're all very comfortable rattling off codes and rattling off descriptions. Sometimes the descriptions we've used have nothing to do with what's actually in the documentation, but unfortunately that's where we're living at. So you want to keep in mind moving forward when you start cross-mapping these codes and understanding what was and what's going to be, there could be some changes, and most of that documentation is right there in your coding guidelines that are documented on there to help you understand that. The other thing is to understand is that not all ICD-9 codes have ICD-10 mappings. Not all ICD-10 codes have ICD-9 mappings. A lot of us probably have already seen that in the HLI lookup system, and to understand that that is going to continue being in there, my advice moving now and forward is that if you're providers and you're assessing diagnosis, always use a more appropriate code. Choose a more appropriate code versus choosing something that doesn't have a mapping, especially in this time frame. So if you choose ICD-9 now, it is going to go ahead and go out the door. But yet, if you're in that habit of using it, then once October 1st rolls around, it's going to be an invalid code. So you want to make sure that if you're coming across certain codes in there that you don't see a 10 mapping, that you go ahead and move forward and try to find a more appropriate code that you're using. And at this point, if you're using an ICD-10 without ICD-9 mappings, vice versa, you still want to look for a code that's going to have the mappings. Once October 1st rolls around, if you have codes, because there's many of them that do have just ICD-10 codes in that, it'll be fine to go ahead and use those moving forward, because when the claims go out, they're going to go ahead and be what they're supposed to be on the ICD-10. Other things in there is the ICD-9 codes. Some have one-to-one. Those are nice, easy ones that what it is what it's going to be moving forward. The other ones with the one-to-many mappings, those are the ones, again, if those codes are specific to the site where you're working and have to move that, those are the ones you want to focus on. Understand what is the requirements behind there and when it is I use those separate codes and what it is I'm going to need, and how that might pertain as to what I need to do in my templates and anything else that I'm going to be moving forward to use those. For a period of more than 2 or more years right now, systems will need to access both ICD-9 and ICD-10 codes. So if there's a question out there, is if you're thinking that ICD-9 codes are going to go away October 1st, it's not going to happen. We still have to have the ability to go ahead and bill, or I don't want to say bill both codes, but I want to say be able to have the triad codes and the option to have either the 9 or the 10 information on there. And then overall, knowledge of ICD codes such as the cause, location, type, and counter, and how these codes will have the effect in daily workflow is very necessary to this transition of ICD-10. And so, it goes to say you don't have to go out there and learn the 63,000 codes, but you have to learn the codes that are going to go ahead and be pertinent to what you do every day, and to be able to start getting very familiar with what it is you need to use in order to get your claims to go out and to cause less heartache on the end moving forward. So when I talk about mapping ICD-9 codes to ICD-10 codes through the diagnosis table, the whole purpose of this is to understand 100% is that when in Practice Partner, when you go to the diagnosis table and you want to map an ICD-9 code to an ICD-10 code, the idea behind that, what that is doing for you, is updating the problem list as a whole for your patient records. The other thing it's doing is establishing it is in the office code section. If that office code section of the diagnosis table equals the ICD-9 code, when it gets mapped, then that recognizes the mapping, such as when you free text, type in like the diagnosis code in the ledger and so forth. If that is mapped, it's going to go ahead and recognize that that has a 9 and a 10 to it. If it hasn't been mapped to the diagnosis table, which not all of them will be, then it's going to require that somebody uses the HLI lookup to be able to make sure that they have the triad of codes coming through. But the purpose in this whole exercise right here and updating these is to give you the ability to actually go in and update those and then reach out to all of the patients and patient records and update their problem list to have the appropriate mapping that's needed. When I say not all of them are going to be, you probably are going to run into codes that had laterality associated to them in the past that when you update them, you may not have a choice to be able to go ahead and update them at all at that point. And if that's the case, it's going to be left in the problem list and then can be updated manually as lists get cleaned up as we move forward. So I'm going to go ahead and we're going to talk about using that maintenance table and updating the problem and diagnosis. Yes?
Before we do that, I'm going to ask again, there are some folks on this call that don't have your line muted, and we are getting some background noise. So I would appreciate it if folks would mute their phones so that the rest of the audience can. Thank you.
Thank you.
Go ahead, Susie.
Thank you. All right, so in Practice Partner, under the maintenance tables and the problem diagnosis, we have our diagnosis table that switched in version 11 to what you're seeing here in this information here as it goes through. And the idea behind this diagnosis table is to be able to update the codes for the triad codes to have an ICD-9, an ICD-10, and a SNOMED. once updated through there, as I said earlier, if you have an office code, such as in this demonstration I'm showing right here, that when you choose an office code that is an ICD-9 code and you map it through that protocol, that's how it recognizes in the patient's problem list to go ahead and update that to the ICD-9 and then the SNOMED code. However, at this date and time, most of you have been up on it for a while, and maybe you did or didn't do the diagnosis table. And just once you got upgraded, you just went ahead and started working in the HLI lookup and assessing codes that way. What happened through that process is that it actually started creating a database behind the scenes, somewhat kind of like you're seeing here. These are both ICD-9 codes, but a lot of times you've probably brought up codes and you've seen the same code. The actual office code with the ICD-9 was not mapped, but everything below it, you had multiple different options in there, and the ICD-10 code actually existed in the office code section with zeros added to it. And that's just the result of the HLI lookup. It's built to create a diagnosis table in the background. So if at any time, if you went to access that and that web server was down and it wouldn't open, there's a little box that pops up that you could click on it, and it actually is going to have the diagnosis table built in the background with the mapping choices that you need. So that's what it's doing in the background. And so once you go into this table at this point, you may want to go in and update some codes. And when you see that information, you're going to kind of be stopped with an option that you can't do this. And so I'm going to walk you through today how to actually get those codes mapped to update the problem list as a whole, so that moving forward in ICD-10, then your problem lists are on their way of being nice and cleaned up as they go through. So the first step I'm going to talk about is just basically mapping it. If you wanted to go in and map the code, the ICD-9 code generally, you bring up the diagnosis table. You're going to search by office code, which should equal your ICD-9 code. So if you've got your list of common diagnosis codes, you're going to look at it, enter it in right here under the office code, and hit search. And you can see in this one, if I was searching by 300 or I wanted 300 series of a diagnosis code, I'm going to highlight it, and then I'm going to go ahead and hit edit, and it opens up this mapping table. Now, earlier on when we first got started with version 11, we were able to go right into this description window and choose the advanced code search here, and it would walk us through that process, and the goal was to be able to implement and put in an ICD-10 and an ICD-9 in this window here, click OK, and it would go ahead and save, and it updates our table. But what I want to bring to your attention through now is that you can also use this same process, but instead go right to the diagnosis code mapping versus using this first tab. And the idea behind that is because if it hasn't been previously mapped, it's going to go ahead and map for you through the same process as you did. You'll click the advanced code search, the HLI lookup, you'll re-enter the code, it'll give you your option, click OK, and it's going to actually go in and map the ICD-9 to the ICD-10 and fill into this information here. So you can use that option versus the description option. And the reason, again, what I'm saying that is because due to the time of everybody being up on version 11, if you went to the description field now and tried to do it, you're going to run across the warning coming up saying it can't do it because there's already a code set established for this. If you do it through the diagnosis mapping, you're going to have a couple of different options on there, which I'm going to talk about here as we move through it. So again, like I said, if you click the advanced code search, it's going to open up the HLI system. You get to put your code in again, the diagnosis code. And at this point when you're doing this, you want to search by the diagnosis code, not by the text. And the reason is because we really want to just narrow it down to those codes. Once it comes in, you'll click OK. And then you're going to come up and get this little pop-up, and it's just saying to you that this change is going to result in immediate update of the codes for all patients with the active problem in their problem list. So in other words, if 300.00 was my ICD-9 in problem list for all my patients in patient records, by doing this exercise, once I click yes and OK, it goes out to every one of those patient records on the problem list and updates that problem list with this particular SNOMED and this particular ICD-9 code. The one-to-one mappings are easy to do, and the idea behind that, because it is what it is, and it's going to move over into the 10. This is what I'm saying is that you might have things that come up to it, and with laterality associated office status codes may not be something that you want to go ahead and update. Those may be something you just leave in the problem list, and as you move forward into ICD-10, those get updated manually through the problem list automatically. But you can get a lot of your main codes that you're using just to get them mapped through here in order to get your problem list in a position where it's going to be easier to get them cleaned up. Once you put OK on this, you can see then that it pops back into my diagnosis code table just like what you're seeing, and everything is good. It's all mapped, everything's cool, and moving on. All right, so the next step on this is what happens when you already have been using the HLI, and I explained earlier that you've got a lot of codes out there that you've got to see it, and you may have tried to map that diagnosis code at this later date versus when you first got started. And when you go to map it, it gives you a warning and says can't do it because there's already code sets mapped in here. So in those situations, if you want to go back and map those, and an easy way to tell things that would need to be mapped would be if you opened up a patient's problem list. And there's a lot of ICD-9 codes in those problem lists that are not mapped. And they've got a 9, but they don't have a 10 associated with them all. So that's an indication that those codes have never been mapped through the problem list at all. So those particular codes, and moving forward, if you go ahead and come through this process, open it up, go to the diagnosis mapping, click your advanced code search, walk through the process we just talked about, you'll be able to get and clean up a lot of those. But some of those codes that come in that have been used previously that you weren't able to update if you were using the description tab is going to pop up and give you this warning. It's going to tell you that those code sets already exist. And do you want to go ahead and proceed? And what it's asking you at this point, if you click yes and OK, it is going to actually go through a utility, go out to the problem list, and update that diagnosis code in the problem list as a whole. All right? So you can go ahead and update those if those are codes that need to be updated and get them done. The one thing I want to warn you on is when you do this, it works and it works well, but it does take time depending on the size of your database. So if you have a pretty good sized database going out there and you're going to work through this process, once you click yes on this feature right here and move through it, it's going to go ahead and tell you it's going to take time, and it does. So it's not like something that somebody can sit down and get done, relatively fast if the diagnosis codes weren't mapped. So just keep in mind when you sit down to do that process that it will and it could take time, again, depending on that size of database information that goes onto it. Once you click OK, what will happen down in here is that the OK will gray, and you'll think, oh, I froze up. You're not. It's running, and basically it's going out and looking at all the problem lists, and then it's going to go ahead and update. And then at that point, you're going to get a little processing bar that kind of runs right up along right in this area here, and that is going to show you the process of getting it done. Once you see that processing bar, then it doesn't take too long after that it gets all of your problem lists, it gets all that diagnosis code in the problem list updated, and then that's done. But just keep in mind, again, as you move through it, you may have multiple codes that you have to do each one of those and get it done on that. The one thing that also to keep in mind is when you update through this diagnosis mapping and at this late date, it's going to go ahead and update your problem list, but when you get done, your diagnosis table is still going to look the same way as it did prior. And that is due to the fact that those code sets already exist. So this second part of it is just a utility to go back in and run and get those diagnosis codes updated so your problem list is clear and utilize it, but you will not see that mapping here inside the diagnosis table. And there again, with this diagnosis table, where that would come into play at any time is if that web server went down and somebody had to access this diagnosis table, they would already have the choice of using another one of those codes versus this, the one that had the ICD-9 as the code, office code information. So just kind of keep in mind that you will see that, and it will not update, but your problem list will as you move forward. I just added this little warning in here because I know that it's kind of an ongoing, and I even know from my own experience when we first got on 11 was we would update certain codes, and then you'd go in to update more, and you'd pop up and get this little error. And so this is the error that more or less would come up if you tried to update a diagnosis code through this description tab versus the diagnosis mapping tab. You'll go ahead and get this warning, and then it wouldn't let you move beyond that. So just kind of keep in mind that that's why I'll direct you to the diagnosis mapping tab versus using this description tab, and it'll make it go a little bit smoother, and then you shouldn't see this error come up in front of you to be able to get through that process as moving forward. So as you update your problem list, I can say the process probably cleans up 70 to 80% of a problem list depending on past workflows. And the reason I say that is because in 952 and prior, we could use those dot codes to push down into that problem list without a lot of requirements. We didn't have to have a diagnosis code. We could push different information down in that, and there was a lot of uses for it in the past because we could. When version 11 came along, that went away for us. And so we can't just push anything we want down in that tab without associating it with a diagnosis code. If you had an ICD-9 associated to this code, it's going to go ahead and continue down to the problem list, and then it's going to be there, and it'll show up in the problem list as black, but then you won't have your list for the ICD-10 or the SNOMED code overall. So what we just talked about using the diagnosis table, that's really the area of ICD-9 codes for the most part that you want to capture to get those updated into your problem list so that it comes out looking kind of like this top one that we're seeing on there, that everything's mapped and looking very nice to go through. The other thing I referred to through this was that there's going to be codes that maybe should not be mapped at the level of the diagnosis maintenance table, and then you're also going to have some of that stuff coming over from ICD-9 that would not have a diagnosis code associated to it, and you'll be seeing that in red in the problem list like I have down below. Two reasons those are going to be in red. One is that there's no diagnosis code at all associated to it, or the diagnosis code that's associated to it is inactive. And most what I've seen that would have been if prior you were using like a 3-digit code that really required to move up to the 4th or 5th. So when you get your problem list updated like that and implementing it into ICD-10, in your workflow, you really want to start looking at these problem lists and getting to the point where if you have to incorporate when at a manual level, once that top part is done and you've updated as much as you can, 70 to 80% of it possible, then the next is added to have when somebody on the other end of it, when they're coming into problem list, being able to update the problem list to a level that everything is mapped to the triad codes. Move through. So, the question is, and I've had this go, so why should I clean up my problem list? I don't even look at my problem list. Moving forward, ICD-10, there's a few tools in there that have changed. One, we brought the ability to bring the problem list into the order module, which is right there, very easy to use, to pull those diagnosis codes into it and to be able to use it. That's one reason. The other reason is to allow for the use of the Shift F8 in the progress notes. If that problem list isn't updated and you have providers utilizing that, they're going to continuously, and it's not updated, if they're using it, they're going to continue pushing down ICD-9 codes. So that is one reason to be able to get the Shift F8 up and managed with the whole sections of codes so that it gives them the ability to use that Shift F8 to push and pull codes back and forth into their note. The other thing is to think about this, to me, is a great tool. Moving into ICD-10, if maybe I have chronic illnesses at this point that I just want to have chronic illnesses, nothing's changed. It allows me to push and pull diagnosis codes back and forth into the note, utilizing them in a couple different ways. So that's one reason to be able to get it cleaned up. The next, as I spoke about, was the ability to use the problem list inside the order module. If these are not mapped up, when ICD-10 comes around, if they were to try to use a code on there, one, they're going to get the bells and whistles going to go off saying this code is invalid. But the next is to be able, if it's all mapped, then they can go ahead and drag and drop their diagnosis codes from the order module, from the problem list right into the diagnosis tab, to make it easier on them and not have to go in and search for more codes, information that goes on. So that's another reason to have those problem lists cleaned up, to be able to allow the workflow to move through and to keep that data nice and going. The one thing that I'll point out at this level, again, with your orders, is right now we're seeing ICD-9 in this window here. Once ICD-10 comes around October 1st, you will start seeing ICD-10 codes in there. So again, if they're mapped, it'll be easy for the provider to go ahead and put their mouse and hover over those diagnosis codes to be able to see that there is a 9 and a 10 in order for them to start getting familiar with the codes that they need to be able to use and pull into that system. And the last is why clean up the problem list is for those of you participating in meaningful use, and maybe you're not, but at some point moving into the future, we're going to be to the point where we're actually sending out clinical summaries. Patients have availability to get into the web portal, look at that information, as well as sending data, exporting it out in the form of a CCDA to other providers. And so by keeping those problem lists cleaned up, it's just going to make things look better as you're exporting information out. So as a whole, just a few reasons to get that problem list cleaned up and make sure that they're cleaned and maintained, because it is part of the record, and it's going to tie into quite a few other things in there involved on that as well. So again, talk about cleanup problem lists. I just brought this in as to moving forward and incorporating it into your workflow if it's not happening now. As these problem lists get cleaned up, you can move problems from one tab to the other if that's what's required. If it's appropriate, maybe it has to be removed altogether or made inactive. But you can do a lot of different options in this problem list to be able to get them cleaned up. And for all the reasons involved to have a clean problem list, it'd be wise to go ahead and have that start moving into your plan now. Obviously, you won't have problem lists cleaned up by the time October 1st rolled around in most situations, but it's something that you could start implementing now to be moving forward so that it does get to that point in the near future as we get this implemented. The next thing I'm going to talk about is updating templates and quick text containing ICD-9. You're going to want, if you haven't already, gone through templates and identify certain things in those templates that need to be updated. Last July, clinical tool template, there was a download that was sent out, and there was some updated templates in that release that you can still have with the templates now with clinical tools, and it has updated some quick text and some templates, not all of them, but some basic ones such as the chronic illness disease template, CAN templates type like that you can go ahead and update, and they're going to go ahead and you can bring them into your system. Understand that you use the merge utility to do that with, so when you do it, you want to make sure that you understand whether you're going to just bring them in over current CAN templates or if all of your templates you've used have been saved with an asterisk or something to that extent so it doesn't overwrite, stuff like that. But if you went in and you've customized templates and not saved them to a different name, if you use that merge utility template and the question comes up and asks, do you want to overwrite those templates, and you say yes, it will overwrite that customization. So just know that if you bring those in, to understand what questions you're answering before you bring them in so that you know that you have what you need and what's expected afterwards. Some of them is useful as it comes in, but the other thing to keep in mind is that most of us have been a practice partner for many years, done a lot of customization. If you've gone in and changed names or if you have your own customized quick text, those will have to be updated by hand. And it's important that you start identifying which one of those are and to be able to go in and get those updated. Because if they're not updated and they're still being used, once October 1st rolls around, it's going to error out and it's going to force them to go ahead and switch over and find the diagnosis code that they need. So by getting those updated now, you're going to be able to implement it and be ahead of that and get that changed. Most of on mine of it, the sites that I've worked with, we like to start with high volume templates or prioritize that way. That way the templates are being used most often. We can get to those first, and then we can identify what's in that. Many times the same quick text resides in those that reside in a template that doesn't get used that much. So if you can get through and get those updated relatively fast, then you've done a lot of work foremost and be able to get a lot of those templates done as you start moving forward to it. The other thing in there, and I'll talk about this later, is make sure that you document what gets done so that you know, okay, I've got this one done, I'm going to move on to the next and next. So you're not constantly repeating yourself as it moves on to that. And then obviously if you're doing some internal testing, that's a good place to catch things that are not updated that need to be updated. Information goes through. So to update quick text containing ICD-9, it's just a matter of going in to your template like you see here and going down and opening up the quick text you use, editing it, and then in this demonstration you can see you want to go ahead and edit that. You're going to highlight that whole line and then come down and click lookup. And then once the HLI lookup comes in, you'll have to re-enter that code. Once it comes up, just like what we did at the diagnosis table, and once you click OK, if you have this line highlighted, it just is going to copy and paste it right over the old existing information that's in there. So it makes it easy. If you don't do that, then you might run the chance of going in and updating it and getting an extra dot code right over in here. It'll add to what you already have in there. So it's just a little quick way of highlighting that and then bringing it in so it pastes over the top of it, and then you can move on to the next and to the next. So it's not a hard job to do. It's just tedious as you move through on there to be able to get it updated. The other thing that you're going to want to look at when you're updating quick text is the complexity of ICD-10. And when we kind of refer back to that top 50 codes that you've already pulled and you've used to update your problem list and everything else and use as a guide, at that point you should still look at that. And if you're in an area and you understand there's certain codes that you use that's in that list that's going to be used ongoing and there's requirements, moving into 10, that is going to dictate some more quick text work that you have to do. So in this example right here is like the foot pain template. You can see all of the extra diagnosis codes in here that's been added to it because you have a right and a left. So that would need to be added to it if they're going to go ahead and use the quick text on that option to be able to choose that, and it comes all the way down to everything that's in that foot pain. The hip pain is also large. You know, any kind of musculoskeletal type templates are going to have a lot of adding to it. The other thing is what you might want it to at this point is if you had a list of top 50 diagnoses or, you know, that kind of thing that was pretty popular in 952. Keep in mind that that list of top 50 might turn into, you know, the top 150, 200 codes. And at that point, you're really got too much quick text for somebody that's really going to go ahead and search for that much quick text. And it might be a decision as well on the site side to say, you know what, maybe at this point is where we limit the quick text to what we have, and then they're going to have to start using the HLI lookup a little more for certain types of codes. It's a decision that you make. I mean, there's no rule that says you don't have to have all that quick text in there, but it's just an understanding of what you're going to have and how much information they're going to have to pull down and what they're going to look at as it moves through. And this particular demonstration I have here is the foot pain injuries. That is a code set that really needs to be paid attention to because anything with an injury on it requires that you have a code type associated with it. So in something like this, you might have a foot left and right, but you also are going to have an office visit associated to it. So keep in mind that as you bring those quick texts up, looking at it, if it's codes that require extra work, make sure that you're looking at your ICD-10 code books or guidelines, whatever it is that you're using, and understand what you need to have in that. Because by setting this up like this, then you're setting everybody up to be able to do what they need to do and to get those codes over appropriately. The other thing that you're going to want to look inside like this is especially with injuries, if it's documented in there that they have to report extra information with that, such as burns. Burns are big ones that they're going to have to report where they were at and what they were doing when they got burned, and which requires 2 additional codes. So you definitely want to look at all of those requirements on there to determine how much work you're going to want to do in these quick texts and get them updated ongoing. This next area there kind of lays into what I was just talking about is, again, on the top 50 codes. If you've got more information that, per the guidelines, require that you report more than one diagnosis code, you can actually go into your quick text, just as I've done here with osteoporosis, and been able to add extra quick text in here that would give them the ability to go in and add those extra codes that are needed, so that it documents here, and then it's going to go ahead and push down to your billing or give you the ability to get it out on that encounter, because it will be required that it's billed in a situation like this. So this is just an example of osteoporosis. There's some changes coming into it, and with this case is before, they may be treating it for it, but they may have to add extra information on that. So it's very important, again, that you go through those codes you're currently using and the ones that are used regularly, and they're associated with quick text, to be able to get these updated inside of that, so that you give everybody the opportunity to be able to be doing it right, versus going in and having things push over and then having to go back and redo things as it progresses through to that. The next step, I think somebody doesn't have their phone on mute again. All right. So the next step is to look at that beyond your quick text. You've got a lot of that going on that you're going to have to look at, is to then next identify certain things that we did in 952 that may be associated with diagnosis codes, such as hard-coded dot codes, such as well exams, well child. All of those have hard-coded diagnosis codes in there, so you're going to want to go through those and get those updated if they're not updated already. And then behind that, there's going to be some hidden quick text, such as in this example, you've got that well woman exam abnormal findings is found in the well woman visit, and then the labs and the annual physical also has diagnosis codes down behind it, so you're going to want to go through and get those updated and identify what's going on. Same with your children. Also in social history, there's the alcohol and smoking. You want to go ahead and get those updated, because they both have history of diagnosis codes that are hard-coded in there inside the quick text, to get those updated so that they'll flow over the way they need to and be appropriate when they get into your billing system. The other area here is like with your immunizations, this particular one, you can see that your quick text is set up as ICD, DCAP ICD-9. You want to get those updated, and then if it were me, I would just rename them to be ICD-10. Of course, that's going to require that you rename them in quick text as well as rename them on your template, but at least you're moving into that mode to be able to get them done. But it's still important that these get identified prior to October 1st or your internal and external testing, because if not, you're still going to end up doing a lot of fixing on the back end, and so it's just being kind of proactive on that. The other area to look at is if you had any PR3s that were associated with, you could go ahead and put the procedure code and the diagnosis on that. You're going to want to identify any of those utilized in that, and to be able to get those updated or used to the process that you need to. And then if you had any diagnosis codes such as hospital or risks that were pulling down into the template that just had words to it without an ICD-10, you should have already had errors on that by now, but you still want to identify that. The other area that I've kind of worked with other sites that I've come across, but they've had some of those codes hard-coded in the past where they could go down and we could just type information and push it down the problem list. You probably should have already seen errors like that coming up, but if you haven't, then you'll want to identify those and get those fixed, because it will cause problems moving forward as you move on. And then the last is, are you using any conditional logic within the templates that can be associated with diagnosis codes? So you may have templates out there with conditional logic that if this, then that, and then it would go ahead and populate a diagnosis code onto your template. Make sure that you've addressed those and got those updated as well moving forward on those templates, so that it'll go ahead and move smoothly as once that date comes around. Earlier, I kind of just talked about, as you start doing this documentation, the whole idea of implementing this plan is you may be the one person sitting back and doing the work on the practice partner configuration side of it, but by keeping a nice organized plan involved and documenting your work, the end result's going to be that once you get all this done, you're going to have a training plan associated with everybody on the site so they understand what the changes are and understand what it is they're going to see. And so by keeping kind of a spreadsheet of some sort and doing some sort of documentation on there that's needed, it's going to help you be able to go back and recognize what templates you did work on, what you didn't, or maybe help you find something that needs to get worked on as well. And that way it's going to just keep you nice and organized as you implement through to be able to keep everybody on track and what has been changed or what still needs to be changed. On the prenatal flow sheet, there's really not a lot of work that really is required on this in general, because once you went to 11 in that pregnancy problem list, it required that they went ahead and started using the new diagnosis code in that system on that. This pregnancy problem list will not be updated as of the other problem list by using the diagnosis table. It's separate, which we all know, it's a separate little module down there. But just understand that pregnancy problem is what it is moving forward, and you won't have to do much work in there other than, again, if you're using the .pp to push things down into the pregnancy problem list, you'll want to address those. And then if they're using the pregnancy prenatal templates and so forth, you want to make sure that you go ahead and get those updated accordingly to what's needed and the changes. I just add a little side note on there. Due to the changes in ICD-10 coding, the documentation and training specific to OB is pretty important that they understand what it is that comes through, because there are quite a few changes on that. So if you have people working in that and you haven't done a lot of training right now, it's advised that you do look into doing some of that so you understand as that moves through as to what's going to be needed in that certain discipline. Once you've got through all your templates and your quick text, which will take some time if you haven't done it yet, or to start working through it, it may be an ongoing work in progress, but definitely it needs to be working right now and getting it moved forward. The next step to think about on that is the order names. And if you have diagnosis codes associated to insurance, right in here in this demonstration that I'm showing, and it's associated to codes, you want to make sure that you go in and get those mapped correctly as well. Because if they're not mapped, then it's going to go ahead and error out, and it's going to require, it'll probably pop up, if it's Medicare is associated, it's going to force you to go ahead and print an ABN and all that kind of stuff going on with it. So you definitely want to address, if you're utilizing that these get updated to the triadic codes that's needed on there so that it continues to work the way it does, and it doesn't cause a lot of problems trying to get those mapped the way they need to go ahead and be mapped. The other area that you want to address, and some of it may or may not, depending on your discipline, but most of you are probably using the problem diagnosis synonyms that are associated with health maintenance. And that's really what happens in there is when you go in and you use the problem diagnosis and health maintenance pops up and says, you know, we have a template for diabetes. Do you want to apply the health maintenance template to it? This is what drives that. So you do want to go through there and look at those problem diagnosis and update your synonyms with that. The only options you have is the problem diagnosis or the pregnancy templates. So if you're not dealing with the pregnancy templates, health maintenance templates, or the pregnancy module, you wouldn't need to worry about that one. But you probably should go ahead and address the problem diagnosis because it does tie into a lot of different things, even with meaningful use and the clinical decision support role. So you want to make sure that that is all being captured and updated through that process to be able to bring the appropriate codes into that. This is just another picture of your, I mean, again, it's with your pregnancy problem list and just updating it through the synonyms. The next is the electronic encounter forms, and with that, if you're using it, some of you may just not have an electronic encounter form at all. You're pushing things down from the progress note or the orders. That's fine. You're doing all your work in your templates and your problem list and so forth. No address needs to be that. But if you are using an electronic encounter form and you have one created, then you will want to come in here and be able to update all your diagnosis codes that you had in there prior, because prior you had ICD-9. So it'd be a matter of just coming in, checking them, looking them up, and it's going to go ahead and map them to the sections of codes that you need to go have on there. So just make sure that that's on your radar if you are using an electronic encounter form to get that updated. And like I said, if you're not, then you don't need to worry about that. Standard or custom order reports. Just keep in mind right now is with the patient records, the standard order form and the custom reports right now are going ahead and they're reporting ICD-9 codes. Once October 1st rolls around, when you print those out, those are going to change to ICD-10. You won't have the option to be able to see both codes on the printed forms. If you're doing electronic order forms outbound, those both will have both code sets on them, but the printed forms will not. So just kind of keep that in your mind right now as you're seeing that move forward, and then knowing that on that date, that's where you're going to start seeing those changes going forward. So there again, those codes to be mapped or to have the triad of codes on there so that once those forms change over, it has the ability to choose which code it needs to go ahead and print on that altogether. All right. TikTok. We're down to the wire on this information. I want to just stop for just a little bit and see if there's any questions that we've gone over so far as patient record configuration goes. All right. Can I go back a slide? Right here. Is this Amy? Is this what you were looking at?
Yes, that's what I'm looking at. So the printed order form, we won't have to make any changes. Like, you know how you have to go into forms and, like, that's a really tedious little horrible thing. So we don't have to do anything to that?
No, as long as you, I mean, if it's what you like right now, because your fields are pulling from the diagnosis fields. So, you know, that's what's going to go ahead and replace it. So you don't have to do anything with it, but just understand that, you know, once October 1st rolls around, what was going to be 9, it's going to now say the ICD-10 on that. So sure. You shouldn't have to go in and do any of that tedious work.
Oh, that's awesome. Thank you.
Yeah. Yeah, those kind of make us all cringe, don't they?
They do.
All right, so I just had to add this in there with the TikTok, is understanding that we are not that far away from that date, and I commonly refer it to as the day the world will change as we once knew it. So we're getting very close to that. So understanding that, you know, if you're not ready for that or you're not doing anything to get ready for it, please start doing it, because the more prepared you are for anything, the less of an impact it's going to have once we do that switch over.
For reports, you can run the diagnosis analysis report of the 50 to 100 diagnosis codes used?
Yes. And are you on Practice Partner Medical Billing?
How do I know?
If you're on Practice Partner Medical Billing, then that would be the analysis of diagnosis codes found under your analysis reports and medical billing, and you can run that one. It's going to give you a summary of diagnosis codes, and you can do it for a time period, so it doesn't, you know, you can't, it'll just bring up your diagnosis code and, as a summary, and say how many times it was used. And if you do it for a time period, I would say you could probably go back. It's going to capture it with even the last 4 or 5 months. Your top diagnoses are going to still be your top diagnoses on there, but it will give you a date frame to go ahead and use that information as to what you want to see to be able to use it.
Nice, buddy.
All right. So I'm going to go ahead and move on to medical billing. And again, this slide is pertinent to Practice Partner Medical Billing information that I'm showing on that. But in this particular case, in the carrier maintenance screen, understand that any practice management that you're using, there is going to be a setup in that will allow you to dictate what code set is going to go out on your claims. And so you will be able to continue sending old claims out, or if it's And keep in mind, October 1st, I doubt if very many of us are going to be billing October 1 dates on October 1. That's going to come a little bit later. So we may still be entering charges on October 1 for September, the end of September. This little diagnosis code setting in here is what is going to dictate what codes go out on those claims. So when we think about PRUTIL's default setting of October 1st of 2015, this is also dictating this right here. You can see right below here, because I have this set as a default, use the ICD-10 diagnosis codes starting on October 1st. This is pulling right from PRUTIL. So as far as practice partner is concerned, if in your carrier it is set as a default, this means that on October 1st, as you start pushing claims over, if your date of service is October 1st and forward, it's going to kick out ICD-10 codes. If you are still billing dates of service prior to October 1st and your carrier setting is at default, it's going to continue billing out ICD-9 codes. Okay? So just keep that in mind, that this is what it's going to do. When you got upgraded to 11 in your carrier setup, this was all set at default. I don't know if at some point somebody was going through that thinking, oh my gosh, I need to make sure I have that as ICD-9. So I would advise that you go through and kind of look at your carriers to make sure that's still saying default in there. And if it's saying ICD-9 and it's Medicare, make sure that you've got it back to go ahead and say default. So that way then it's going to go ahead and let the system do the work for you, vice versa. The other option that you're going to have in here, and again with your carriers in general, any covered entity is required to go to ICD-10 as of October 1st. A covered entity means our commercial carriers, our Medicares, or all that information that goes through that we go through. A non-covered entity is going to be workers' comp, personal injury, that kind of a carrier. So if you're living in that world that you're doing a lot of work comp and personal injury, highly advisable that you get on the phone with them and find out what is going to be their requirement, because if they're going to still continue recognizing only 9, then you would want to change your carrier setup for that particular carrier to ICD-9. So that way, once October 1st rolls around, you're not sending out ICD-10 claims to them, a diagnosis to them, and they're getting them returned. So you're just going to want to make sure that you verify those type of carriers that you're working for. And like I said, those are non-covered entities, which usually is work comp, personal injury, that kind of carrier. The rest of them are going to be covered entities onto that information that goes through. And if there's a question on whether they are or not, get on the phone and find out or go to their website. But your big carriers will all be changing over. So as you move forward, understanding what's in here is what's going to dictate what goes out on the claim. So you will always have the ability to go back in and bill old claims, work in your accounts receivable if you have to go back and rebill a claim from let's say May of this year. That claim is sitting there and it's ICD-9, and whatever the carrier is, if this says default, you'll be able to go ahead and rebill that. And then moving forward, it's going to recognize the difference. The one thing I'm still going to stress as we move through there, talking about updating your diagnosis table, updating your problem list, using the HLI system. You have to be able from now on going out, if you have not been very consistent about making sure the codes coming into the system have the ICD-9 and the ICD-10 and the SOMED code associated to it, you need to start doing it now, because if you're not, and that you're in the habit of doing that, once you start sending out codes, like with this one, if it says default and you're going in there to the ledger and you're typing in, 300.00 and it hasn't been mapped, it's going to pop up and say code's invalid. So just through the whole thing of this is stressing the importance of making sure those codes you're using the HLI or the triad of codes so that these systems can recognize what code set that they need to go ahead and bill out on that. All right, this is just going ahead and talking about that carrier field and information that goes through on that. The other option you have in here is in the case of testing, if you're going to go ahead and send out a test claim, then you would want to change this carrier coding set to ICD-10. And that way then when the codes go out, it understands that it's trying to send 10 out to your testing environment as well. But then you go back and make sure you change it back once you're done with your testing.
Homework or whatever too.
All right. This is just kind of the same information and just kind of me stressing about making sure those codes are all rounded the way they need to be. The other thing that you're going to want to look at in medical billing is if you have any default diagnosis codes set up into the procedure code maintenance. And in this case, you will want to make sure those are updated, because if they're not updated,
Out there, guys.
It's separate from that problem. And you're going to want to make sure those are, because if they're not, and in a situation such as I've seen a lot of people have, like immunizations, that kind of stuff, they were defaulted in there. And so it was causing problems once we got to the testing system, which was good that we identified them then, but just kind of make sure that's on your checklist of things that need to get updated before you go live on, or actually the compliance date comes around. That way it's going to save you some time and frustration of understanding why claims are not going out the door. And the other window you have in here is your patient window with the default diagnosis. If you have anything set up in here, those will also need to be updated manually over and above what you've done so far through the other options. In the ledger, you do have the tooltip that comes through here that you can see right in here. And it's no different than in the order module or anywhere else. If you hover your mouse over it, it's going to go ahead and show you the mapping that comes through on that. And when we first started this presentation, I said something about mapping the diagnosis to this office code. Keep in mind that what comes over to the ledger is really the office code. What we see is the ICD-9, and so, or 10. And so as you've moved to 11, you probably were in a situation where you might have seen codes coming over, and they looked like ICD-10, and then you had some mixtures of 9 and that kind of thing pulling into it. The reason is the way they were coming through that. But you want to make sure either or. I could still have a mixture of a 9 and 10 on my ledger, but if they're mapped, then you're good, because depending on what that carrier is set to is what's going to go out on that claim. So you just want to make sure as you're recognizing this. The other thing that, and I can see a lot of billing people that I worked with on the practice partner side of it, and if I were sitting in your shoes, I'd be just as guilty. We know diagnosis codes like the back of our hand, and we're just typing those away. And like I said earlier, if that's the habit you're into and you get into your charge part of the ledger, if those codes are not mapped back on that diagnosis table, then they're not coming in here mapped as well. So you just want to make sure that that's a habit that you've been doing, and that everyone understands that they need to or may need to launch the health language lookups from the diagnosis table here if they're entering in by hand, and make sure those codes coming in are completely with the ICD-9 and the ICD-10, so that everything, the system knows which direction to go on those. This is just a picture of going in and making sure that those are updated in there, and if not, then you're launching it right from this window and typing it in and bringing it in from the health language system on that to be able to go ahead and implement, so that you have the 9 and the 10 on that. So basically, if you have done any testing so far, or you're going to get ready to start some, you'll be able to identify some of those issues right off the bat, because they'll error out when you start going through your validator in Practice Partner. The other option to look at, too, is then if you are pulling things over into the electronic encounter form from notes, when you edit procedure codes and through the little window that pops up here that we're seeing, if you're going in and adding your modifiers and so forth, the other option is that, and most of us are used to going in there again and just free texting that diagnosis code into it. That's what we've been doing for many years. That also is another functionality that needs to be a practice that needs to be updated on you guys in, and a conscious effort of being able to go ahead and look those up. Obviously, if you've got everything set up coming over from notes correctly, you're not going to have to worry about this window so much. But, you know, as we start implementing through there, any of the billers that are looking at this level, you want to start really identifying codes that are coming over in the ICD-9 without the ICD-10, because right there is an area where there's some kind of a setup somewhere that needs to get addressed and get them updated, so that you don't have to constantly go in there and change those codes. In your HCFA file for your electronic claim file, there's some qualifiers in there, information that goes through. And this is just basically what shows up in that claim file as to how it knows what codes to send out. So it's just these qualifiers in here. The information that you're seeing is what goes in that claim file to recognize that there's a 9 or a 10 information that pulls onto it. And as you go ahead and send out claims, especially on the testing side, you want to make sure that if it's going out of partner okay, but then you're getting errors back saying that the diagnosis code is not correct, then there's an issue inside of your claim file. And if you update the patches, we had a recent patch that was just released last week, is going to go ahead and take care of that HICFA file on that. But if you have that issue, then it's definitely make sure that you're addressing your patches information coming through. But that is what's in your claim file to go ahead and make sure that the claim gets on to Relay Health in the appropriate code set that it needs to go ahead and go through. Testing on internal processes. If you haven't done any testing, I still highly advise that you do testing one way or the other. I mean, if it's just, I'm going to start from the very beginning and I'm going to start all the way down and I print the HICFA out and I change my carrier to ICD-10, and when I get that claim, ICD-10 is on there and everything's beautiful, you should be a happy camper. The other thing is if it's not, then to sit back and go back and identify where the errors are. What are the areas that you're going to have in Practice Partner? Like I said earlier, if right now testing, if you still have an ICD-9 code that's not mapped with a 10, once that code goes into and gets validated, it actually is going to error out that level. And when you look at it, you're going to be able to see, like you might have a diagnosis 1 that is blank. Diagnosis 2 has an ICD-10 code on it. That's your first indication to know that that diagnosis 1 is not mapped to an ICD-10 code. So internal testing in general, I mean, if you haven't done any more at all, I would still highly advise starting at the top of whatever method that you're using to get those claims out to be able to go ahead and identify areas of that, because that is going to be, if it's not being done, then come October 1st, you're going to have warnings go off, but there again, it's going to slow you down having to go back and get things fixed versus keeping on moving in that progression as you go forward on that there. So you definitely want to do some internal testing, document the testing. If there's issues in templates, that way it goes ahead and gives you a place to go back and make sure that they're fixed. External testing has been going on for quite a while now, and if you're using Relay Health, they have the dashboard that you can go up, launch onto it, and it's going to give you a dashboard of your carriers and what kind of testing is option. Now keep in mind at this date, late date, I'm going to say, is Medicare has actually stopped doing any testing, which overall I think that's a good sign. That's saying that their systems are working pretty good. But you can still send test claims to your clearinghouses. If you're not using Relay Health and you're using something else, you'll want to go onto that website and find out what testing options they're using and how you do it. But you definitely should and continue doing it. I know the sites I've worked with and we've done testing with it. We've really been able to kind of narrow things down, identify that there were workflow issues that we needed to address, or templates and that kind of thing going on to it, because you can still send them to Relay Health and you're still going to get a response back from them in 837, which is going to it's an accept reject. So if it goes back and everything gets passed on through your Relay Health edits, then you're going to feel pretty good knowing that you got through that first set of edits, because they have their edits set up to identify areas as well. So if you haven't started doing it, I'd highly recommend that you do make some plans, because you do have a little bit of time left to go, and to be able to just give you an overall idea of how things are and what's in your system. It's moving on to that and just kind of make you feel that maybe you're more on top of it than you thought. So just make sure that you're taking that time and doing some sort of testing, internal, external, either or both, and it's sure going to, I think in the long run, benefit you overall. The other thing on here is down at the bottom is when you do test, you don't have to create new claims. You can go ahead and rebuild claims out of Practice Partner Medical Billing, basically by taking claims and I always recommend current claims, because this way is you want to make sure that things have everything, the best ability that you've had to use in the system, I guess. But let's say you create a batch of claims and you send them out to production right now, you could turn around and take that section of claims and rebuild them in the test mode and send them right back out to Relay in their testing mode, and be able to identify that. And there's a mixture on your Relay Health website. It'll tell you what claims are accepting or what not. And when it goes into testing, it's going to go ahead and it will give you options to come back on that. So like I said, your big carriers, we really don't have a choice at this point to get any kind of end-to-end opportunity on that, but you do have the ability to get them to relay and look at edits. Last on this implementation, and I've kind of mentioned as it goes through, but develop a plan for physician and staff education and workflow changes. As you work through, and my experience so far has been is the external and the internal testing has really brought forward a lot of workflow things that were going on that we were able to address and get back to the entire staff as to certain things that was going on in order to make everybody's lives easier. And so as you have that plan, it's highly recommended that you get this together, you make sure everybody's on the same page, and those changes are sent out to everyone so they know what they're doing. The other thing is on the back end of it, earlier in the beginning of this slide, I talked about financial and just kind of having an idea as to where you're at practice-wise, financially. Continue that plan afterwards, because as things come in, you know, you're going to have money coming back in from the end of September. We're going to move right into November and steal some money from previous, but then we're going to start seeing payments coming in for our ICD-10. You want to know where those are at. What's happening with that? We're not going to have any, we have no new, at this point, they're not giving us any new reason codes to have put into the system for our electronic ERAs coming back in, so we should have the same denial codes that we had in the past. Nothing new on that, but you're really going to want to make sure that you're monitoring that so that you understand what's going on and being able to act fast on it versus just waiting for it to change or thinking that it is going to change on that because it's new to everybody. So just make sure that, you know, even after ICD-10 that you continue monitoring and understanding those changes coming in, and continue with that education as it goes through, because it, as we know it now, it's just going to keep on building on itself. So just understanding that implementation is, we're going to get through that date, but we're going to continue working forward to make sure that things kind of get back into normal. And I would monitor them for a while. I mean, probably put it to the end of the year at this point. Probably by December, you were going to have a good idea as to how everything's going, but you definitely want to make sure you're staying on top of it so nothing gets out of control. These are just some resources on here that's going to be on your slide that you come back through. Like I talked about, coding, documentation type training, it's really a must. There really is not an excuse not to get it done. It's very important. And so here's some options for different training options. We have some with McKesson Can Help information that we offer some of those services on that end if that's something that you can do, the AAPC. And then the Medicare Road to 10 actually has a pretty good module on there that is, they've got some specialty specific type training going on, information that goes through. So there's just different options, and it depends on how much you want to spend on that and how much you want to get it done to be able to do it. But really, everyone has to do it. And then these are resources, information that comes through that you'll have on your slide. Last is we have a website here for the assistance at McKesson.com, similar to the Meaningful Use email, that you can go ahead and email questions and that kind of information, and we'll get back with you on answers that may be something that can be easily answered to you right via the email or take action on. All right, any questions on any of this? Okay. Sounds like everybody's ready. Go ahead.
Will this be recorded?
Yes, we've recorded it.
And will that be available to the VARs to get a copy?
Yes.
Okay, thank you.
Hey, Susie, phenomenal job as always.